Hey, healthcare friends, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you, written in your style and ready the moment the visit is over. All you have to do is give it to your patient. Just imagine leaving the office at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. Well, today we've got part 2 of the 10 Commandments of Polypharmacy, and I'm going to cover my last 5 commandments, commandments 6 through 10. So just a little bit of a background. I put together these commandments to really help people identify ways to reduce medications, and it's an ongoing challenge. The statistics show that more and more patients are being put on more and more medications over the years, and polypharmacy is growing, and it's going to be an issue for the foreseeable future. So with that said, let's get into some of the commandments here. So number 6, thou shalt identify limits for medications not intended for chronic use, as well as not continue medication indefinitely for symptoms that have an expected short duration. So that's a little bit of a mouthful, but I'll provide you some examples here. So classic example is DVT. So sometimes for DVT treatment, that DVT can be caused by a certain situation, whether it be immobility or a medication or cancer, that type of thing. And in some situations, long-term DVT prophylaxis may not be warranted. So ensuring that we have set in place an anticipated stop date, or at a minimum, at least a reevaluation date to see if that medication can be continued, or can or should be continued. Antibiotics. I have seen rare cases where antibiotics have been prescribed, and one particular case I remember, the provider wanted to give the antibiotic for 3 to 5 more days, and so they wrote for that order, I believe it was for 5 days, to continue to give it, but they did not put a stop date on it. They just said continue the antibiotic for 5 days and then reevaluate. And that never got reevaluated. The antibiotic continued long term, and they were actually on the antibiotic for several months. Nursing staff involved thought it was for prophylaxis and to prevent future infections, and the provider did not catch it right away that it was on their medication list indefinitely. So miscommunication can lead to outcomes like that sometimes. A couple others to think about: acute pain. So if a patient has an injury and we prescribe a chronic analgesic medication, well, if it's a short-term acute pain type situation, ideally we should be able to get off of that pain medication down the road. Insomnia is another one. Anxiety. A lot of times in geriatric patients will have traumatic life events, such as maybe a death in the family, for example. And patients will, experience anxiety, insomnia, and everything that goes along with that grieving process. And we put them on an anti-anxiety medication or a sleep medication, and that never gets reassessed. So if it's anticipated that there's going to be an issue short term, really, really important to identify limits and be clear with communication on those limits of when therapy should be stopped and or at least reevaluated. All right, commandment number 7, thou shalt not start a medication from a similar medication class without appropriate rationale. So this would definitely be classified under the duplicate therapy type of section. Some things I've seen in practice that I don't love and don't think should be done. ACEs and ARBs, I've seen those used together occasionally, whether that be intentional or unintentional. Typically, ACEs and ARBs absolutely should not be used together. DPP-4 inhibitors and the newer medications, somewhat newer medications, I guess, GLP-1 agonists, those work along a similar pathway in the way that they basically increase the amount of incretin or enhance incretin's effects. So those generally should not be used together. I've seen quite a few alpha blockers used together in my practice as well. So something like prazosin, which is a non-selective alpha blocker, used maybe for nightmares or psychiatric purposes. And then patients with BPH, maybe adding tamsulosin on board on top of that. So again, another example there of potential duplicate therapy. And then psych issues. So I've definitely seen kind of continuous prescribing when problems don't resolve and not reassessing medications that have been added in the past. Very common with antidepressants, where we just kind of keep adding and tweaking the antidepressants rather than reassessing the original one that was added and say, hey, is this really working? Is this really helping that patient? And in some cases, there may be a partial response for a patient, and we may try to do add-on therapy to get them a little bit more, and that may be appropriate in certain cases. But again, I think that reassessment of when you have to add more medication for a condition, you better ask yourself, are we already treating this condition with other medications? And obviously reassess, did that medication actually do something, the original medication that was started? So antipsychotics, I've certainly seen this. Insomnia medications, I've certainly seen that as well, where we just kind of continue to add and never look back and see that they're already on a medication from a similar class. Thou shalt not initiate a medication without considering medications that may treat duplicate conditions. So this is commandment number 8. I would probably also refer to this one as the kill two birds with one stone commandment here. So if we have medications that can do multiple things or have the potential to help multiple conditions, this makes a lot of sense to utilize. So we're not using two separate medications. So, one example I've seen in practice is, maybe using a loratadine for some itching, and then they're having insomnia as well, and so we start zolpidem, for example. Well, anticholinergic medications aren't the greatest and safest in the world, but in this type of situation where we've got a patient with some itching issues, maybe particularly at night, something like a doxepin, for example, would be a reasonable consideration, so we don't have to utilize two different medications to kind of treat two separate indications. So if you've got those type of medications that are having numerous indications or can be used to treat numerous indications, that's definitely something to think about. A couple of other examples that just kind of come to my mind, beta blockers, in cardiovascular disease, atrial fibrillation, also potentially maybe some benefit in like migraine prophylaxis. So there's a good example where we can maybe utilize kind of multiple effects from a medication to treat numerous conditions, and we can get by with just one medication rather than a medication for migraine prophylaxis and a separate medication for atrial fibrillation, for example. One last example I wanted to mention was mirtazapine. It's got some sedative type properties. Obviously, it is an antidepressant as well, and then tends to be on the weight positive side. So if you've got somebody that's frail, not eating well, depressed, and they're having trouble with insomnia, mirtazapine seems like a relatively good fit there in most situations. All right, number 9, thou shalt consider eliminating or reducing medications at every medication review. Now, I can tell you from experience that this definitely does not get done by everybody all the time. So I think if you're a prescriber, if you're, a consulting pharmacist like I am, whoever, I think it's important to change your mindset. And particularly targeting polypharmacy and say, hey, is there an opportunity to reduce or discontinue any medications? And then go through their medication list and say, hey, yes, I think this vitamin and supplement, might have been helpful at one point, but I don't think they really need it anymore. Let's say heartburn. They haven't had heartburn in 2 years. They've been on a PPI. That seems to be their only indication. That's the only reason why that medication was started. Can we taper that off and potentially get rid of it? So again, changing that mindset to review the medication list every time and have a focus on, can we reduce something? Really, really important. I would also add that when new symptoms come up, that is also a very, very critical time to review the medication list because we definitely could be causing the prescribing cascade. So if somebody reports a new onset of leg swelling, you better believe it's a great time to look at that medication list and make sure that we haven't added any medications like a pioglitazone, for example, or maybe a gabapentinoid that could increase the risk for edema. Okay, so very, very important to have that active mindset in saying, hey, I'm going to look at these medications and I'm going to go through one by one, making sure we've got a good indication for them and making sure that we're not causing any adverse effects either. All right, and then number 10. Thou shalt be willing to accept risk in discontinuing a medication if they were willing to accept the risk of initiating medication. So it is very, very easy when a patient has a medical concern going on to start a medication. We want to try to solve that problem. We want to try to fix it. But what often gets overlooked and not really thought about is when you start somebody on a medication, you're taking a risk. They could be allergic, they could have an adverse effect, they could have a drug interaction. Whenever we add medications, there is risk involved in that. And I think when we deprescribe, when we reduce medications, I think providers tend to be very keen on that. And that there is some risk in deprescribing because there is the potential that the symptoms will return for whatever whatever medication that we're taking away. So I think it's important to have that mindset that, if you're okay with starting new medications and, potentially causing side effects and causing other issues, you should be okay with taking away a medication and potentially having them have their symptoms come back of the disease state that we were trying to manage. So, but with that said, appropriate tapering and reduction is really, really important. I mean, that's one of my biggest pet peeves when you've got a patient on a big dose of PPI, let's say, 40 milligrams of omeprazole twice a day, and, the provider will just discontinue it cold turkey. They've been on it for years. That's not an appropriate way to do that. They're very, very likely to have rebound symptoms. We got to make sure that we're doing things appropriately and tapering that off over time. It's okay to take your time. It is definitely okay to take your time and taper off medications rather than just doing the cold turkey approach, which can definitely lead to more problems. And there's certainly medications that are much, much higher risk than others, as far as taking away and that sort of thing. I think of some of the antihypertensive, for example, where we can have, rebound hypertension, significant rebound hypertension if we take them away abruptly. Beta blockers, clonidine, things like that, or some of the opioids. Benzodiazepines obviously have some serious risks associated if you go from, a big dose to nothing too quickly. So really, really important to think about that. So some targets within kind of the realm of this commandment of accepting that risk in discontinuing, I think of some of the patients with subjective symptoms. So urinary incontinence, that's a good one to think about, where we can target some deprescribing. Insomnia, restless leg syndrome, GERD symptoms, heartburn symptoms, pain, muscle spasms. Can we reduce some of those medications? Another one I've seen come up is in diabetes, where we've got sulfonylureas, which are stimulating the production of insulin, and then down the road, it's not effective enough, or whatever the case may be, and we want to start insulin. Well, do we really need to complicate that patient's regimen and still have that sulfonylurea on board? So, again, just some good examples there of things that I've seen in my practice where we can try to potentially deprescribe and, of course, reduce polypharmacy. All right, well, that's going to wrap up the podcast for today. Go support the sponsor, med101.com/store. We've got great board exam materials there to help you prepare and pass for your NAPLEX, BCPS, and many others. So go check that out at med101.com/store. If you enjoyed this podcast and want a free PDF on the top 200 drugs, great little study guide, great refresher, go sign up at reallifepharmacology.com. Simply an email will get you access to that. Of course, leave a rating review on iTunes or wherever you're listening. I greatly appreciate that. And of course, share us. Friends, colleagues, students, anyone who could benefit from some pharmacology education. If you got comments, suggestions, feel free to reach out to me, Eric Christensen, PharmD, BCPS, BCGP at LinkedIn. Otherwise, you can track me down by email as well, mededucation101 at gmail.com. And with that, I'm going to sign off for the day. Thank you so much for listening, and I appreciate your support.